Hey everyone, we're going to be dropping the walls for the breakouts, and we're going to be starting those breakouts around 12:45.
Yeah, exactly. Can I have yours too? All right. Good afternoon, everyone. It's barely afternoon. Welcome to the Housing Is Conference and the workshop on healthcare and research in housing. My name is Peggy Bailey, and I am the Director of Health Integration at the Center on Budget and Policy Priorities. We're a nonprofit think tank here in DC that looks at how to protect safety net programs for the most vulnerable. I lead our Connecting the Dots project, which looks at the intersection of housing and healthcare policy for those populations, really thinking about for those but for housing won't engage in services, and without strong services won't be able to maintain their housing. How do we integrate policy for them to make access to the services and housing that they need as easy as possible for them? This workshop is particularly interesting to me. I'm really excited because it shows the different elements of the healthcare system, which is important for us as housers to understand. Our work speaks to the healthcare system in a variety of ways. And it's very important to us, for us to be able to know which message speaks to which audience. So for this workshop, you'll hear about housing, the environmental impacts of housing, which from a healthcare perspective is more in the public health space, thinking about healthcare outcomes for people, and is a great message for your county public health department. If the Centers for Disease Control come to town and have an innovative project, those types of services. Then you'll also hear about population-based health needs for housing needs for health population, and especially in the seniors case that Dan will talk about, also has a cost impact. And it's important for us, over the last couple of decades in the housing space, we've really focused in on this cost conversation. It's important for us to do that responsibly and to know which audience that conversation plays with best. It's if you're going to go to a hospital and talk about cost savings, you have to remember that that isn't cost for them, that's revenue for them, right? So you have to think about, maybe we need to figure out what population, like seniors, are important to them to be able to serve better. But if you're going to managed care, and there have been several opportunities the last 2 days to talk to managed care organizations, then the cost argument comes into play. If you're talking to your state Medicaid office, cost comes into play. And especially if you're talking to us at the federal level, cost comes into play. So understanding the messages, and that's what Craig and Dan will both be able to help you do. See what impact is housing having on health, and then that'll allow you to think about who is the right messenger for that, so that we can get more healthcare partners engaged in our housing work and housing advocacy. So the structure for our workshop today is each presenter will present. We'll have a little bit of time for questions, but because the topic areas are unified by health, and that's health and housing, and that's pretty much it. We're going to treat them as two separate sections. So Craig will go first and present his work. We'll have some questions on that, and then Dan will go next and present his work, and we'll have some questions around that, and we'll hopefully still have some questions that are more overarching, time for questions that are more overarching. All right, so with that, Craig.
Great, well, thank you. It's really a pleasure to be here talking with this group and trying to connect the dots, as Peggy was talking about, around kind of the connections between housing and health. So I want to start with this map, as many of you are probably familiar with. So these subway or metro maps have been produced by RWJ, and I think they're incredibly powerful. So here in DC, downtown, where we're having our meeting, the life expectancy is 77 years. Incidentally, this is also where I live with my family, in an area just by the orange line. If I were to move with my family to Montgomery County, I think there's really important questions of, would my life expectancy increase? Am I doing my kids a disservice by staying in this city? I don't know the answer to this. I think these are incredibly, incredibly powerful maps, but they raise a tremendous amount of fundamental questions about what's going on, what's underlying some of these maps. Is it the context that we're living in? Is it the composition of the people that live in these areas? And what should we do from a policy perspective about helping people move potentially to areas of opportunity? So I'm going to be talking today about 2 studies that give some purchase onto some of the underlying mechanisms of this map, trying to help explain some of the healthcare use that may be associated with people as they move. So I'm going to talk first about a study that we've been doing with Moving to Opportunity, where we tried to link data sources between a housing and administrative health records. And then the second study, getting kind of a little bit more granular, talking about the way we partnered with the Housing Mobility Program in Baltimore to understand the impact of housing mobility on kids with asthma. So the first question we're asking is whether moving with a housing mobility voucher in MTO was associated with healthcare use and spending. And I just want to take a moment to highlight the enormous team that's been involved in this project. Brad Herring is an economist, as well as Stephanie DeLuca, a sociologist, Rachel Thornton, a bunch of other folks that have been involved, as well as the funders, including RWJ, HUD, and Hopkins Population Center. So I think in this audience in particular, I probably don't need to go into MTO in detail. As everyone probably knows, from the mid-90s, HUD ran this amazing social experiment. And basically, they randomized 4,500 families to 3 different control groups, or 3 different study arms. The first was a control group of people living in public housing, low-income families, in some of the poorest neighborhoods across 5 different cities. The second was a traditional Section 8 voucher. And then the third was an experimental voucher that for the first year had to be used in a low poverty neighborhood. And then they followed these families for a long period of time. So there's been a number of previous studies using MTO. And I feel like last time I was at a housing conference, Allison Bell had a picture of Raj Chetty that kind of spun around because it's gotten so much attention, talking about the ways that children in the experimental arm who were less than 13 years old at the time of randomization had higher earnings and were more likely to graduate college as an adult. Adults' physical health showed some reductions in diabetes and obesity using really nice measured outcomes. And then there were some mixed effects on kids' psychological health, where girls tended to do a little bit better and boys tended to do a little bit worse. And there's a lot of kind of qualitative work trying to understand some of these differences and these findings. We wanted to try to add on what's been shown with MTO by linking MTO with administrative health data. And for this, we had 2 different types of data. So the first is all-payer hospital discharge data, and then the second is Medicaid data. And for folks in the kind of housing world, I want to spend a little time talking about the different data sources and the advantages and disadvantages of each. So the all-payer data is what the hospitals actually report to the state every time somebody is admitted to the hospital, or in some cases admitted to the emergency department. And it includes information about the date of service, as well as the date that they were discharged from the hospital, and all of the different diagnoses and procedures that are attached to that particular encounter, that care encounter. We link this by specifically social security number, date of birth, as well as gender of the MTO participant. And I got to say, I know that like some of the ways that data exchange happens can be really problematic in thinking about these kind of partnerships. For MTO, because it was a study, participants signed informed consent. And we try to work really closely with HUD and the different state agencies to try to silo the data so everyone just had the data that they need to complete the project, but not have too much data to try to protect people's confidentiality and privacy as much as possible. The second source of data that we had is state Medicaid data. And Medicaid data is a little bit different. So all payer data includes everybody, regardless of whether they're uninsured or whether they have private insurance, Medicare, Medicaid. Medicaid is an insurance arm, and so it just includes people conditional on them actually being enrolled in Medicaid. And for this, it includes both inpatient as well as outpatient utilization. So every time they go to the doctor, every time they go to the hospital, every time they go to the emergency department, as well as the associated procedures and diagnoses that we can try to use. And it's a little bit like trying to extract kind of in the tea leaves, because Medicaid, because it's administered by the state, each state is a little bit different in how they sometimes code things, how they classify things. So it's a little bit more messy than we'd like, but I'm happy to talk about that as well. So these are the different data sources that we had. So again, MTO covered 5 different sites. In California, Massachusetts, and New York, we had all payer data from these different years, and from Illinois and Maryland, we had state Medicaid data covering about a 10-year span. And so I think these calendar years are not that informative, and I think it's much more useful to try to turn these into years since randomization, which is how we thought about them as a research team. So saying that, okay, in California, we have from the year after that a participant was randomized all the way up to 17 to 20 years after randomization, depending on exactly when that particular participant enrolled in MTO. Similarly, for New York, we have between their first year after randomization up to 21 years follow-up. I just want to say, like, when we're thinking about kind of what's the health impact of housing, being able to look at long-term outcomes and have these outcomes be actual, validated outcomes and are not based on self-report is incredibly, incredibly useful. So you can see the different data sources that we had and the years that we brought to bear. So overall, for adults, we had about 54,000 person years of data that we were able to consolidate. And for the kids, we had about 122,000 person years of data that we used in our analysis. In terms of the cohort that we were studying, we looked at about 4,000 adults and 9,000 children. For adults, the mean age at randomization was 33, and based on the design of MTO, almost all were female. About 2/3 were Black, and 61% were never married. For the kids, the mean age was 8 at the time of randomization, and about half were male, half were female. And then I also want to remind myself on this slide to mention that when we're talking about 21 years after follow-up, we're starting with it when a kid was on average 8 years old. At the end of follow-up, they're no longer kids. We talk about them kids at randomization, but they become young adults over the course of the time period that we have, which is nice to be able to follow them over time. Also, when I spoke to a lot of the kind of housing advocates about this study, a lot of people were like, oh, you're still using MTO. We hate MTO. This was before Raj Chetty's study came out, so there was some disgruntledness about MTO as an experiment, because the idea that a lot of the current mobility programs are doing a lot better at helping families move and stay in opportunity neighborhoods. And I think this kind of speaks to the concerns that a lot of my colleagues had about using MTO. So you can see this is a chart that shows the average poverty that families experienced in the first 5 years after randomization. And in the experimental arm, the group that got the voucher to move to a low poverty neighborhood, the average poverty that they experienced in their neighborhood was about 40%. For the traditional Section 8 arm, it's 40%. And for the control arm, it's about 50%. These changes are not enormous, right? Like, they're not the type of changes that you would want to see. And I think this is due to a number of different factors. So one, the lease-up rate in the different study arms was not as high as we would have liked to see. So only about half of families with a low poverty voucher were able to successfully move. 63% of those in the traditional voucher were able to move. We also had some of the changes in the control arm with Hope 6 and some families moving out of low poverty neighborhoods. And so in the end, kind of from a statistical perspective, it's kind of blunting the effect that you're able to see over time with this type of study. So there's some limitations that I just want to point out with that. And because of that, we combined the two different voucher arms because the rate of poverty experience was so similar. And this figure is the kind of the main takeaway point from our study. So this is looking at hospitalizations among younger children. The red line is the control arm, and the blue line is the experimental or traditional voucher arms. And what you can see on the x-axis on the bottom is the time period since randomization. On the bottom, you have kind of the number of person years of data that we have, or the number of participants, I should say. And what you can see here is that the experimental and traditional voucher arm, the blue line, is constantly lower than the red line. The rate of hospitalization among young children, less than 13 at the time of randomization, tended to be lower. When we kind of put these into kind of more robust models, we see that this resulted in about a 17.5% reduction in hospitalizations among children who had the opportunity to move, the opportunity to use their voucher, whether it was a traditional voucher or an experimental voucher. This resulted in about $200 less spending per year per child for those given a voucher. So this is looking at all children, regardless of whether they actually move their voucher. When we did some additional analyses to say, okay, but what's the actual effect given that people use their voucher? Conditional on voucher take-up, here we see that the effects are magnified. So accounting for voucher uptake, we see about a 30% reduction in hospitalizations over this up to 21-year follow-up period, and about $350 less in hospital spending. And when I talk to people about this, they say $350, like, okay, it's, maybe it's good, but is that really a lot? I would make the case that this is a yearly reduction, and again, we're seeing it over the 20 years, so kind of multiplying by 20, thinking that there also may be more than one child in a family that you're helping, and so you can potentially multiply by the number of children in a family. So I think these actual reductions are incredibly significant in terms of what they mean for the potential for neighborhood conditions to impact hospital spending. Kind of just a little bit more on the findings. So when we looked at it all told, we found lower rates of hospitalizations and spendings for children, kind of any age less than 18 at randomization. And they were significant for younger children and girls in the voucher groups compared to the control arms. It remained significant for hospitalizations that started in the emergency department. So you showed up at the emergency department and then later get admitted to the hospital, as well as for pregnancy-related hospitalizations, which tended to be about half of the reasons why girls were hospitalized, as well as non-pregnancy-related hospitalizations. In contrast, we didn't see anything going on for adults. The kind of lines, the red and the blue lines were right on top of each other. For older children, we also didn't see any significant effect, and if anything, it looked like the impact might have been in the reverse, with potentially higher healthcare use. And in addition, for boys, we didn't see a significant effect. When we looked at emergency department use on its own, we also didn't see any difference between people in the control versus the voucher arms. So we looked at this another way as well. Rather than just looking at voucher versus control, we also said, can we use this amazing experiment that HUD ran and try to look at what's the impact, the causal impact of neighborhood poverty in ways that try to disentangle that kind of, is it where people are choosing to live, or is it about the composition of the neighborhood? And so here we used housing vouchers as what's called an instrumental variable, and we looked at what's the change in healthcare use associated with a 10 percentage point change in neighborhood poverty. So that's like moving from an area of 50% poverty to an area of 40% poverty. And here we looked at it kind of, if you experience poverty in the first 3 years after randomization, which is like kind of where MTO saw the biggest changes, and then looked at health outcomes in years 4 through up to 21. And here we saw about a 15% reduction in hospitalizations and $140 less in hospital spending for young children that had the chance to move with a 10 percentage point difference in neighborhood poverty. So again, really significant. And if you can imagine where you're multiplying this by, maybe we're seeing a 20 or 30% percentage point reduction in neighborhood poverty, these savings we think are incredibly significant and can accrue over time. So I'm going to shift gears. So that's kind of where we've been with the MTO work, which we're really very excited about. And now I want to talk a little bit about what we've been doing at a kind of a smaller scale, looking at what's the impact of housing mobility on asthma. And for this, I'm going to be talking about the Mobility Asthma Project, which is NIEH, a National Institute of Health funded study. And for this, we also have a really fantastic study team, which includes Elizabeth Matsui and Corinne Keat, who are co-principal investigators with myself. They're both pediatric allergists, so tremendous expertise in pediatric asthma. So here we decided to focus on asthma, in part based on what our housing partners told us that they were seeing in families that were able to move, had the opportunity to move to a low poverty neighborhood. And we thought, oh, this is a fantastic target condition, in part because the rates of asthma in inner cities like Baltimore are incredibly high. So about a quarter of kids in inner city Baltimore have asthma. And we also know that environmental triggers play an important role. In Baltimore, mouse allergens as well as cockroaches are some of the main triggers of asthma exacerbations, leading kids to use more of their inhalers, miss schools, and end up in the emergency department and in the hospital. And we also thought moving was a potential solution for these types of allergens. I should say that there's been a lot about home remediations in studies with asthma, so kind of giving families bed covers, helping them with air filters, helping them vacuum their homes. And I would say that those studies have been important, but a lot of them have had somewhat disappointing results. And I think these types of pictures at the bottom in Baltimore kind of give you a sense as why that might be. It's really hard to eradicate mouse and cockroach allergens in an area, in a neighborhood that's endemic. It's hard to plug all of the holes in your home when you might be living on a block or in an area where there's a lot of abandoned houses where your neighbors are not necessarily making those same remunerations and remediation to their homes. So we thought that potentially housing mobility might be a really important solution to some of the asthma exacerbations and triggers that we're seeing. So for this research, we partnered with the Baltimore Regional Housing Partnership, which many of you are probably familiar with. The BRHP started as a result of a fair housing lawsuit brought by the ACLU of Maryland against the state of Maryland and against HUD. As part of their settlement with HUD, they created a class of vouchers that they helped administer, or the BRHP was set up to help administer, which helped families move to areas from concentrated poverty into areas of opportunity, according to specific criteria. They've been really a national leader in creating these models of housing mobility, which go through extensive pre-move as well as post-move counseling to help people remain living in areas of opportunity. Their requirements are that families need to stay in low-poverty neighborhoods for 2 years, although they're finding that the majority of their families do end up staying. And I would say in contrast to MTO, where we saw a 10 percentage point change in kind of average neighborhood poverty exposure, here you're seeing that in 2018, that their kind of pre-move average poverty that their families experienced was around 37%. After they moved, the neighborhood rate of poverty was about 8%. So really enormous changes in the amount of poverty that their families were experiencing. And I would say that kind of parenthetically that they were really fantastic for us to partner with because it really understood and were working with us to understand kind of the research that we wanted to do and kind of why we were committed to trying to show the impact of their type of program on health outcomes to make these partnerships. So the study activities that we've been engaged in and are still ongoing have been quite intensive. So when families come into BRHP, when they get the call that they're potentially going to get a voucher, they start going through pre-move counseling. Our study team is there at the pre-move counseling sessions asking if they have any children with asthma and if they're interested in screening to see whether their children are eligible. Here we focused on kids with moderate to severe asthma, in part because we want to be able to see changes that might happen with respect to moving. And if you include kids with really mild asthma, then you would just need a much larger sample in order to see an effect. So once kids are eligible, we do a home visit as well as at baseline as well as every 6 months. The home visit includes breathing tests as well as baseline blood draw to see what are they actually allergic to, what do they have antibodies to in their blood. We also do a urine test to see whether or not they're exposed to cigarette smoke, and a structured home assessment that includes like vacuuming an area of their bed for a specified period of time so we can collect dust samples. And then there's an extensive survey for both the parent as well as the child. In addition to the home visits that happen every 6 months, I should say that the blood draws only happen at the beginning and the end, so we're not sticking kids every 6 months, but that we also do phone calls in the intervening 3 months in order to collect asthma symptoms. So to date, we have about 123 families that have enrolled. These are families that have a child with moderate to severe asthma. Of these, over half, 87, have received a voucher to move, and 82 families have successfully relocated with their voucher. For baseline allergen sensitization, these are, what are they actually allergic to? We're finding that about 30% are allergic to mice, 28% are allergic to cockroaches, about half are allergic to cats, as well as dogs and dust mites. So nearly 2/3, 60%, have at least one allergen that we suspect may be impacted by them actually relocating to opportunity neighborhood. So this is very preliminary, so I just want to say that kind of these are not ready for prime time because we think that this will change. But you can see what we have here is kind of the different allergens along the left side, and then we have a column for the average amount in the old home versus the average amount in the new home. I told you there was only 120-something people in the study and only 87 or 82 had moved. And again, you have more than that home sampled in the old and the new home, and it's because we've been going into their homes more than once. If they're still in our study in 6 months and they haven't moved, we go into their old home again. And what you can see here is that in, for example, mouse allergens, you have about 6,700 nanograms per gram of dust that's collected. Versus in the new home, it's about 1,200 nanograms per gram of dust collected. This is an 82% reduction in the amount of mouse allergens, which again is one of the main triggers of asthma. Similarly, we saw an 83% reduction in cockroach allergens just on these very preliminary studies. Some reduction in cat as well as dogs allergens. Dust mite going in the other direction, but again, very low levels for those dust mite in both the old and the new houses. So when we presented and talking to some kind of asthma people about this work, they were asking like, what else did you do in the homes? Surely you must have gone in with the air filters and the bed covers in order to get these types of dramatic reductions, which are even much larger than the reductions you would see in these home remediations. And I would say that we didn't do anything. It's just seeing what's happened as they've moved from areas of concentrated poverty into areas of opportunity. I would also say that we're not sure, will this be sustained over time? These are new homes that they've moved into. We go into their homes, up to 6 months after they've moved for the first visit, and then sometime after that as well, trying to follow them for at least a year. When you move into a new home, it's kind of nice and shiny and probably cleaned up. It's unclear whether this will be sustained, but we think that if it is sustained, that this has a tremendous potential to impact asthma. I'm not, unfortunately, going to be showing actually what happened to kids' asthma symptoms, in part because we don't have the results totally analyzed yet, and we don't want to share kind of things that we think would be premature without kind of collecting the data. But I would say kind of a preliminary view of the data, I think, is very encouraging to us in terms of reduction in asthma symptoms, school days missed, and the like. So we're really excited about the potential for housing mobility to actually reduce asthma symptoms. And so this has really led us to this question that I want to raise for the group, which is, how do we think of writing a prescription for healthy housing? What's the role of healthcare providers to partner with housing mobility programs in order to create a case for healthy housing? And I think this case can be a financial case in terms of reductions in hospitalizations, but I also think there's potential moral case as well that we heard this morning around trying to move to address neighborhood conditions and historical patterns. So as we've been thinking about this, we've working with the Baltimore program as well as the Housing Authority of Baltimore City, as well as some folks in Connecticut and other places to think kind of what would it mean for myself as a primary care provider to see somebody who's always coming back to my office with asthma, to have emergency departments that are seeing kids that are constantly readmitted with asthma symptoms and give them the opportunity to move. And I would say that when we've done some preliminary work in the Hopkins ED, asking families that have come in with asthma, very small sample, and saying, hey, do you have a voucher? And a lot of them say, yes, we have a housing voucher. And we ask, would you be interested in a program that would help you move to areas of higher opportunity? And we're finding that over a half say, yeah, we'd be interested in that type of mobility counseling. Again, it's unclear how many would actually follow up and go through the steps that would be required. But I think for me, it raises interesting possibilities that I think have not been well explored. As we've been kind of trying to address this in Baltimore and think through kind of what are the issues, I think there's a number of questions that I would love to throw out to the group. So one question is around kind of who are the partners that would need to be involved and what are the stakeholders that we should think through? Certainly there's a housing authority which might support a voucher, mobility programs that help people move, the health programs that maybe we could try to get to pay for some of the vouchers, for some of the mobility counseling that would accompany the vouchers. Potentially insurance products would be another source of potential funding and a partner to get involved. We've also started kind of working with the health department to think kind of what are the programs that they have to help kids with asthma and how might this be used as like an arrow in their quiver. what are the ways that they can imagine that this use? And I think that these types of kind of novel programs really require people to think outside the box and think about strange bedfellows. I think there's also serious questions about like who we should target. I would say that some of that, kind of housing advocates that we work with say, really we should be focusing on all kids due to the kind of influence of toxic stress to help families move out of high poverty neighborhoods if they want to move out of high poverty neighborhoods, versus kind of more targeting around kids with asthma. And then if we're going to target around kids with asthma, how do we get around some of the HUD requirements around kind of non-discrimination for people with certain chronic conditions, and thinking through some of these issues in really important ways. But as we've partnered with BRHP around these kind of questions, another thing that comes up is kind of what's the role of the housing counseling around imparting information about asthma triggers as part of their pre-move and post-move counseling? Can we augment some of the counseling that they're giving as they work closely with clients over time? Are there ways that home inspections can be augmented to really look for asthma triggers and help advise families? And that's for their new homes as well as for families that might be backfilling the homes that they've moved out of, because I think there's important responsibilities that we want to think about as well. In terms of paying for the model, I've talked a little bit about insurers or healthcare systems, especially under new models of care where we're increasingly responsible for population health management. Are there opportunities that we should leverage right now to try to make the case that these types of investments could matter? And then lastly, thinking about the intended and unintended consequences of these types of programs. I think that often kind of housing mobility programs get pitted against place-based solutions, and I think we want to think of a both-and approach that can be used successfully to try to support families and their health. So with that, I want to thank you all for your attention and open up for any questions.
Yeah, let's open it up for questions for David.
Thank you. Michael Mira, Tacoma, Washington. Thank you for your presentation. Why did you include in your data of the experimental voucher group of those families who stayed in place? I mean, that seems to be beside the point.
I absolutely can kind of hear what you're saying and agree with the kind of sentiment of it. I think one of the things about randomization that is so important is it takes people and kind of randomly distributes it across the different treatment arms. And then you can measure, say, like, 50% of this sample was male, 50% in the control arm, 50% in the intervention arm was male. We got balance on those things that we can look at. The important part is not the things we can look at, but these other unobservable characteristics, the things that we can't really measure very well about your propensity to move and your propensity to seek healthcare and all of these things that are really, really tricky. And randomization kind of allows you to separate those and allows you to really get a good experimental design. And so by kind of analyzing it in this kind of by analyzing it according to the treatment arm rather than whether people moved or not as a first step, it is the most robust evidence that kind of we as scientists can bring to bear on these questions. As a second step, we did do this kind of more kind of advanced analysis on what's called the treatment on treated analysis. So kind of like looking at people conditional on moving, but it kind of breaks the randomization in ways that we just want to pause for a moment on. So yes, I think both are important, but it's kind of about the study design.
David, yeah.
Thanks. David Gazal, Crescent Foundation. So how do you tease out the impact of the move versus in the Baltimore Regional Housing Partnership? How do you tease out the impact of the move as opposed to the probably better conditions of the housing? So in other words, would it have been just as effective to keep people in place for just not just a remedial housing, remediations in the house, but a redevelopment? Since this is clapped on redevelopment of housing, because there have been some certainly studies around the impacts of other social outcomes just on positive redevelopment.
Yeah, no, I think that that's a really important question to say, can we effectively redevelop communities and get rid of some of the asthma triggers through both redevelopment and also kind of going into units and working in the units as well. I would say that in terms of some of the kind of unit-based approaches, that those have been a little bit more disappointing. I think kind of looking at sort of what happens to asthma triggers in like a HOPE 6 redevelopment, I think that's something that's, or a RAD conversion, that's something that is certainly on the table and would be interesting to look at. I still think that there's such, at least in Baltimore, a very high neighborhood burden, from what I understand, of these triggers, that I think it's going to be challenging, but certainly, not out of the scope of something to consider.
Oh.
Okay, Alyssa Erickson, Minneapolis Public Housing. Would it make sense to treat these asthma triggers the same way we treat lead-based paint? So, for example, with the voucher program, they have to inspect, and if they find lead-based paint, it has to be remediated if there's families with kids under 6. Is it something that you could test for like that?
So my understanding is that some of the kind of, and I would kind of open up to people in the room about kind of what do their housing authorities do for asthma triggers in terms of, kind of what's existing. And I think there's ways to potentially augment it, looking for traces of kind of mouse and cockroach infestation, kind of holes in walls and things that are, my understanding is, kind of sometimes part of the inspection process. And so, yeah, thinking about ways that we could work with landlords to try to address that. I think that's going to be important. But again, I would also make the case that even if the landlord is doing their best to address this, and I would say the families that we're working with, know they have a kid with asthma. Many of them are trying to do a tremendous job of keeping their units clean, working to try to do everything they can to kind of reduce allergens, that it can be still very, very challenging.
Does anybody in the room want to speak to that from your point of view as a housing authority?
I can quickly. We partnered with the Summit County Department of Health. Summit County Department of Health, and the third largest killer is COPD and asthma related. And we actually looked at our entire inventory as well as our voucher inventory and found that our place-based, our public housing that we managed and operated, even though it wasn't in a better area, substantially less high-risk asthma individuals were in the housing that we owned. Which was surprising to me. I was very surprised to find that data set, and why I'm very interested in looking at initiatives to incentivize landlords to what I thought was maintain our units to the level, right, that the housing authority did to prevent those asthma triggers. But it sounds like that it might not necessarily be cut and dry, and that there may be like a locational issue as well as a capital improvement issue that might be needed there. But we found something slightly different when we looked at our place-based versus our voucher program.
And where are you from, just so folks know?
Akron, Ohio.
Ah, great, thanks. All right, so
Can I say
we'll.
one quick thing,
sure.
which is that I think there's also kind of the difference between asthma development and asthma exacerbations, and just that a lot of the kind of allergens that we're looking at here are much more important for asthma exacerbations than potentially, and less is known about kind of how these allergens impact asthma development in the first place.
Yeah, and as we, great. So let's thank Craig. Hopefully we'll have time for a couple of more questions. And as we transition to Dan, the only thing I wanted to add is it's interesting. This morning I was with some folks studying rental assistance demonstration program conversions from a health impact perspective, and they were saying the same thing, that it was more of a mental health. The pre-study part was looking more at mental health and actually injury due to violence but they went in thinking that they would find asthma and COPD and those sorts of things. So it's just interesting to think about. All right, Dan.
All right, I'm getting through all the supplement. There we
Okay.
go. Okay. Hi, everyone. I'll talk into the mic. So I've been working in homelessness for 15 years at this point, right? So not kind of relatively long, but long enough to have kind of seen a couple of errors. And I think one of the things that we've noticed kind of, and I'm from New York, I've worked for a while in New York, now live in Philadelphia, there is kind of street homelessness is not the majority in those places, but it is certainly visible in both of those places. It's certainly visible here in kind of the same shelter versus unsheltered environment. And a lot of the things that we're seeing, a lot of the people that we see on the sidewalks, a lot more kind of gray hair, people with canes, people with multiple hospital bracelets than there were 5, 10, certainly 15 years ago. And that's something that we observed and something that we heard kind of anecdotally from largely shelter intake workers in any number of cities that were doing work. And so people started talking about, is there some intervention kind of that we can think about to address what we see as this aging homeless population? And the reasonable answer to that was go do some research and then come back to us. And so we did it. And so what we're talking about is kind of, is there an emerging crisis of elderly homelessness, aging homelessness, and if so, kind of what are the solutions? So we're going to see in part an empirical analysis, and in part a kind of envisioning exercise of what those potential solutions could look like. So I'm putting this up both kind of as an acknowledgement for all the people that participated. Before you saw the whole research team. Now you see the funders, of which there were 4, and 6 or 7 or 8 people that provided data. This was, and I'm Craig, and I'm sure many of you in the room can speak to this, kind of a behemoth of a project to put together as you're trying to get multiple kind of municipal agencies, including CMS, to all give data. There are more fun things to do. But it is kind of, but you could not do an analysis like this in any other way. So again, we're going to go through in part empirical analysis, in part envisioning. We'll talk about kind of what have shelter trends, demographic trends looked like over the last 10 or 15 years. And then we'll talk about projecting those through 2030. We'll then kind of use some of those match data, right? Take that shelter data and then bring in the healthcare data to talk about what kind of healthcare services were people using, how was that clustered, how much was that costing on an annual basis, what can we project from that moving forward, and then how can we identify subgroups that might need particular interventions, and then who might be involved in thinking about some of the next steps. Okay. So part of the question was, we're seeing this on the streets, like, is it just our imaginations? Is there something there? And is it kind of, there's more unsheltered people versus sheltered people? And what we got initially, and that you can see that in this graph, is that there is a cohort effect. Right, it is called kind of the Easterlin cohort effect after demographer named Richard Easterlin, that talked about the second half of the baby boomers, those born between 1955 and 1964, kind of being at increased risk of housing and economic stability throughout their lives. Right, they came in after the first half of the baby boom and came into adulthood after the first half of the baby boomers, and therefore they were kind of late to both the labor market and the housing market, and have been at increased risk of all kinds of adverse outcomes ever since. Right, this was the group that was kind of the face of homelessness in the mid-1980s, and we can see that group, as we move from our light blue bar to our orange line, to our dark blue line, has made up kind of the bulk, kind of the peak of homelessness in the United States for the last 30 years, right? This starts from 1990 and goes through 2010. If we bring this out another 10 years or another 8 years to when we have data, you would see that line, that bump, has moved even farther to the right. And so then what we did is we looked in each of those 3 places and thought, okay, let's map this for people between the ages of 55 and 65 and 64, and then people 65 and older for all the years for which we do have data, and then we'll project it out, right? So again, part empirical and part projection, a little bit of assumption and envisioning. So we're going to show kind of one city for each of our kind of different analyses. Here we're showing Boston, which probably had the smallest population, but you can still see some of those trends here. For those 55 and older, we can see that in 2011, the first year we had data in Boston, we had about 1,500 people in shelter in that year. To the latest year for which we did have data, which was 2017, that number had already jumped to about 2,500 people, so we already jumped 1,000, and we think that's going to go up kind of close to another 1,000 to 3,500 over the course of the next 10, 11, 12 years. And as you can see, that orange group, right, the people 65 and older, that's where we're seeing a lot of that impact. And you can see it even more starkly here, where in 2011 we had about 300 people over the age of 65 that used shelter in that year. In 2017, that had jumped to about 400, about 500. And we expect that's going to go up to about 1,700 over the next 10 years, okay? And we see the same trends across all of our study sites. This is kind of relative population growth for the group of people 65 and older, right? We think they're all three, Los Angeles, New York, and Boston, they're all going to nearly triple, kind of between a growth of 150 to 200% in each of those three sites between 2017 and 2030. Right, New York has the largest group, then Los Angeles, then Boston. It is consequential no matter where we're looking, and it's consistent. And one of the things that we're worried about, right, I mentioned kind of 3 large cities with concentrated homeless populations, right? There is a limitation there that we're not talking about kind of the rural homelessness crisis, which is real, and so are we seeing the same things there? We don't have the data to do the same projections there, but we did look at past data, and we could see that this looks the same in any state that we're looking in. It's at the state level, so again, it's a mix of rural and urban, but certainly it seems to lend some credibility to what we're finding. Okay, so now we're going to move from here, which is just the population side of it, just the shelter use side, to all of the other data that was involved in this. And that varied based on where we were looking. So in New York City, which is where kind of I led the work, we were looking at, in addition to the Department of Homeless Services shelter data, we were using an all-payer claims data of all the hospital use in New York State to look at hospital utilization, and we were looking at nursing home data for the Center from the Center for Medicare and Medicaid Services to look at nursing home usage, right? That was across the country, right? That is kind of relatively limited. In Boston, they had Medicaid data, right? So there is a benefit in that they're including more types of healthcare services. The limitation is they're not including any other payee, or any other payer. So if someone's using Medicare, that's not found here. And Los Angeles had a mix. Okay. What we're showing here are kind of annual costs for the year, for each of kind of these 5-year age groups. And part of what we see is that between the ages of 55 and 69, so 55 to 70, we're not seeing kind of huge changes in the costs of shelter use and most healthcare use during that period, right? Shelter use goes down slightly. That's the dark blue on the bottom. Next up, we have emergency department visits, right? That again doesn't change very much. Inpatient care goes up a little bit. The big shift there is for people 65 to 69, and then again, we see this even more for those 70 and older. We're seeing far more nursing home use for that group as we would expect. It's worth noting here that, right, these are averages. We'll talk about the clustering in a little bit. We'll talk about that again at probably the 30,000 foot level. But it's worth noting that the top 30% of users account for 80% of the costs, right? So it is tightly clustered in that most expensive group, in those most expensive groups. And the top 50% accounts for 94% of all the total costs. That was in Boston. We saw similar things in New York and Los Angeles alike. Okay. Again, we didn't see kind of major changes based on age in shelter use and most healthcare use, but we did see that in the nursing home use. On the blue is an actual usage of nursing home use by age. The black line represents kind of a very smooth version of it. And what it really smooths out is that jump from 64 to 65. As we might expect to see. But certainly we see this increasing exponentially over time once someone hits about 63, 64. Okay. So then we're taking this, right, again, we're building on our kind of analytics to do the envisioning piece of this. Kind of what is this going to cost us on an annual basis? And I'm also going to kind of caveat this, that I'm talking a lot about numbers and costs, and there is kind of a moral argument to do something about this that underlines all of this. So while it's not putting that on the front, kind of in every sentence, it's certainly there and needs to be a part of this conversation. But anyway, going from 2004, this is New York, we're looking at the healthcare costs and shelter cost growth from 2004 to the latest year for which we had data, which was 2017, and then all the way to 2030. So in 2004, about $100 million worth of shelter and healthcare costs for this group, right? Expensive, kind of not shockingly expensive in New York, which is sad in its own right. Right, by the time we got to 2017, the last year for which we had actual data, that had jumped to $260 million. Okay, for this group only, and that jumped and we expect that's going to jump to $460 million, another $200 million jump from 2017 to 2030. Okay, so some real big numbers here in both actual numbers and in percentage terms. Okay, so those are really broad strokes, right? So the next thing is, what can we do about this? Right, one of the knocks against academics is we like to raise problems without proposing solutions, so we like to bring them up. And so that's kind of what we're doing here, and this is our first step, is we're trying to kind of cluster these groups, cluster all of these people. In New York, that was about 14,000 people. In Boston, that was less. In Los Angeles, that was actually a little bit more. Based on their use of shelter and based on their use of healthcare services and their medical acuity. And these kind of solutions varied based on which city we were looking at. In New York City, we had 4 clusters. In Los Angeles, we had 3. We're going to talk a little bit more about Boston, which had 5. But again, we're going to condense those even more just so we can kind of keep this conversation going. And we let the data kind of speak to us. And in Boston, what we had was 2 groups that we're going to lump into one group that are kind of the lower cost, kind of lower medical acuity group. That accounted for about 60% of the group there. In New York City, that was kind of one group that accounted for about 85%. So it varied, but no matter where we looked, that was the majority of people. And again, that lines up with that decile analysis that I was talking about a little bit earlier. And for that group, we're thinking in terms of some sort of progressive engagement model, right? Again, we're kind of throwing out ideas here with the understanding that we are kind of averaging use of services and costs across years, but people don't use the same number of shelter days and same number of hospital days every year from year to year, right? Trajectories switch, right? People are often homeless one year and not homeless the next year, right? 80% of shelter users fall into what we would call a transitional category, where they are homeless for a short period of time, and then they're not homeless again. So we're kind of aware of that and kind of couching our findings in this is a first step toward that trajectory-based analysis that can bring us a little bit closer toward kind of program-level solutions. We're thinking again in kind of a policy 30,000-foot view here. But again, getting back to what we have here, so for this group, we think about a third, based on some work from Margot Kuchel, and who's done a lot of work on elderly homelessness out in San Francisco in the Bay Area. We think we might see about a third of them kind of move back in with family, right? That their homelessness will self-resolve, and that's consistent and maybe even kind of an understatement based on the existing literature. For the remaining 2/3, we're going to break that out evenly. And again, you wouldn't break these out evenly if you were kind of putting this into place, but it allows us to think about this and then create some kind of back-of-the-envelope cost estimates and advance the conversation. So for kind of part of this group, about 22% of this total cluster, we're thinking of some sort of rapid rehousing intervention, which would be kind of a relocation, oftentimes with some financial cost, right? Sometimes it's easy moving someone in with a friend or a family member, but oftentimes you're paying for kind of first, last month's rent, security deposit, things like that, and some time-limited case management assistance. Okay. For the other 2, we're thinking of kind of longer term, still relatively low cost interventions. So again, for about 22% of this group, we're thinking about a shallow rental subsidy, right? $400, $500 a month over kind of for any number of years. Right, expect that's ongoing, again, with minimal social service needs and therefore some sort of minimal case management. And then for a third, right, maybe rental vouchers, right, you're kind of standard housing choice vouchers, again, paired with some sort of kind of light case management. And that's very different than the other groups, which we kind of group together, our kind of Boston groups 1, 3, and 4 that comprise about 40% of that population, where we're thinking of kind of more in terms of the permanent supportive housing model. So we're talking about a voucher plus more intensive social services, along the lines of what you might see with the HUD-VASH or more traditional housing first and permanent supportive housing. In addition to, right, because this is an aging and particularly vulnerable group, some additional needs to allow for aging in place, right? One stat that I didn't bring up at the beginning but is really important is that in the homelessness world, 50 is geriatric, right? Once you hit 50, we're seeing medical conditions in line with those people, your house counterparts, about 20 or 25 years older. And so when we're talking about 50, 55-year-olds, right, that's geriatric in this world, and we expect that that group, especially the most acute of that group, would need some additional care to be able to stay where they're living. Okay, so then continuing the kind of the visioning piece of this, we looked at the literature, we reviewed 15 studies to make some guesses about how much these interventions might cost and how much we might save in terms of shelter use, healthcare use, if we kind of put some scaled version of that intervention into place. Okay, and we came up with two different scenarios. There's a lot of uncertainty around this, and also the literature exists almost entirely around permanent supportive housing, so we're taking some of the findings and service cost reductions from there and applying that to the population as a whole. And we have two estimates. A scenario one that we're calling more conservative, right? That takes all of those 15 studies and applies those findings to kind of this group. And then we have a scenario two, which is kind of either less conservative or kind of a bit more ambitious, and that only includes those studies that found significant reductions in service costs. Okay, so this is showing findings from Los Angeles, and what we're seeing there is we broke this out by our 5-year age groups, and as we see, right, in some of the earlier slides, we saw that healthcare use was kind of the most expensive for the older groups, and therefore we expect that we would save more for those older groups. And if we aggregate that, we expect that we would save a little bit of money over the course of this, right? About 13 or 14 cents kind of net saved for every dollar invested. Again, right, that comes with all the caveats that I mentioned above, but it means that we're in the ballpark. It means that there is kind of, if not a moral reason, there should be, a financial reason to think about how can we advance solutions, right? In New York City, again, we expect that we might save somewhere between $9,000 and $13,000 a year, an intervention cost of about $11,000 a year, and we, again, might save a little bit of money, again, 13 cents for every dollar invested on net. Boston is the counter to that example. We expect kind of, if we're running these scenarios out, that's the only place where we kind of show a loss within the scenario. And a lot of that comes down to the fact, as one of the limitations I mentioned earlier, is that we're only using Medicaid data. So if Medicare or any other payer is paying for any of the services, that's not accounted for, so we're probably missing some savings there. One piece of information that I should also give is, as we're thinking about these interventions, we're also thinking that every person would or could be eligible for SSI, right? Something to supplement their income and something to help offset the cost of any sort of rental assistance. Okay, so getting to kind of the initial question that was on the title slide, could housing solutions be funded by resultant service cost reductions? Yes, we probably wouldn't have put the question on the front slide if the answer was no. And right, that's not a will it be, but could it be? Possibly. It's certainly something to explore, and that's part of how we hope to engage kind of the housing side and the healthcare side, because there are a lot of players in this game, the local area agencies on aging, kind of at the local level, along with the housing authorities, and it goes all the way to, right, the federal government, HUD, VA, CMS, the state government is there administering Medicaid. And with that,
all right, great. Thanks, Dan. All right, let's open it up to questions for Dan.
This is just a very minor. Okay. Were those projected costs inflation adjusted?
They were not. So they were in counts in 2018 dollars.
Okay. Across them.
Yep.
So just a question: Did you guys? I'm you would think that this is intuitively right, but we helped support the National Academy's consensus study on health and housing. Did you consult that research? Because they were less enthusiastic that there were, in fact, cost savings, not that there weren't. It's just that the studies that they were looking at did not exactly corroborate. One of the difficulties, it was difficult to compare different interventions insofar as one person's permanent supportive housing might be different than other person's.
Yeah. Right, and that's part of why I want to put the kind of the brackets and the caveats around these cost savings. Is could it? Yes. Again, it depends on what that permanent supportive housing and those smaller interventions and those cheaper interventions look like. Right, you were talking about permanent supportive housing as kind of a lot of where they're looking. So we're estimating 40% of people looking at permanent supportive housing. A lot of what we're hearing is that's an overestimate of how many people in this group would actually need permanent supportive housing. Right, more we're guessing in the 5 to 10% ballpark, because we're going to see kind of more self-resolvement than we're kind of calculating here. So there is reason to be skeptical. I'm not sure. I'm not sure where to put the balance right now, and that's kind of where we're kind of throwing these out there, saying we need some additional research and some additional analysis to come up with better estimates.
Well, and Dan, would it be right to say that, but you're also figuring in the cost of supportive housing?
Oh, sure.
Which would be higher than what those people who could self-resolve need.
Yes.
Right? So in some ways, there's a little bit of balance there, because you're assuming a very high intervention for more people than will need it.
Absolutely, yes. Especially for, there's some group of here, right? So I think we looked at the average cost of a voucher in New York, and if there's anyone from NYCHA here, you can correct me. I think it was in like the $13,000 ballpark if we included kind of SSI as a source of income for some of these folks. But for the case management side of it, for the services side of it, I think we said for most people it would be kind of in the $15,000 ballpark. I don't have the numbers with me right now. And for some, or 13,000, for some group we doubled that because, and that was, again, probably a conservative estimate. But we would rather err on the side of being cautious and overestimating the service costs than the other way around. One of the things that was, and we only kind of did this piece of that analysis in New York, was that actually most of our savings would come from our least expensive groups. Right, from what we call like our cluster one, our 85% that had the most minimal services, because the intervention costs are so low. That's actually where and there's so many people in that group. Even though the per person cost savings is so low, aggregated over that whole group, that's where we would see the bulk of the savings.
So then there's a need to overlay really that special sauce of the case management on it to see if you would achieve that.
Yes.
For them, right?
Right, and we need some analyses of other interventions. Right, the world has been focused on can we get cost savings from permanent supportive housing, but you have this whole other world. Right, the family option study is the only one really looking at this in any way for rapid rehousing and transitional housing, but that is even at this point kind of dated in a relatively small scale in the scheme of things, and certainly not geared toward this population. So that requires some more work.
Yeah. So one more question, then we'll open it up to both Craig and Dan.
Sure.
On the family options, I was surprised to see rapid rehousing and shallow subsidy as a couple of recommendations for a big piece of the population. Am I right to assume that this population are the folks experiencing chronic homelessness and kind of persistent episodes of homelessness? Or is that a wrong assumption about the population?
Well, for that group, we're not thinking of those for the chronic folks, right? Right. So I'm going to talk to the New York side of it, right? We put up Boston numbers. I'm going to talk to the kind of the New York piece of it, right? We had 85% in that kind of cluster one, which we kind of called moderate shelter use and moderate healthcare use, right? In terms of kind of chronic homelessness, those people are using an average of 40 days in shelter a year, and in most places that's a lot of shelter. In New York City, that's barely scratching the surface. But that's the group that we were thinking of, kind of the lower shelter use group.
And then something I was thinking about is it'd be interesting to look at the cost savings in states with the Medicaid waiver, with doing foundational community supports or supportive housing benefits, and how this could be could be leveraged in this kind of intervention. So.
Oh, absolutely. Yeah, that's one of, we have a laundry list of kind of next projects and ways that we would like to, places that we would like to take this, and we're getting some interest because the 3 cities in which we did this study are not the only ones. There are places that we could get kind of readily available access to data, and even that took 18 months just to get the data. So we, building on this, as other places, rural and urban, are getting kind of interested in this, building that out and evaluating that as an important piece of this.
All right, so we'll let, one more. Oh, sorry, go ahead.
No, you go ahead.
Oh, well, let's thank Dan. And then we'll open it up to broader questions for both Craig and Dan. So go ahead. Oh, be careful. We're going to roll off.
Thank you for your presentation. It was interesting and provocative. It makes me think of what we heard yesterday at a workshop that raised a question that I don't think they quite answered. Let me try it out on YouTube. Yesterday we heard data showing that essentially housing is medicine, that affordable, stable housing makes people healthier. And then we heard in the same workshop that people, and on those grounds, we could wish that everyone lived in subsidized housing, right? But then we heard that people who live in public housing are sicker than their low-income counterparts who do not live in subsidized housing. How should we understand that?
Sure. So I think that there's kind of, when you're thinking about kind of who's living in public housing and their health status, it's really hard to try to separate out kind of why are people living in public housing or in assisted housing, and trying to get at this, what we call confounding in a statistical sense, this idea that that this is not a random group of people living in that receive housing assistance, but that there may be kind of differences by underlying health status that kind of leave people in that lead them to receive housing assistance. And so, kind of we really need to disentangle that. I also think the population is going to be kind of varied, and so that there are going to be some people that are going to be sicker and some people that are going to be healthier, and we need to kind of disaggregate that to understand kind of some of the nuances that are really important in this.
Yeah, I'll second that, and I'll also say kind of, right, you're looking at people in subsidized housing versus people not in subsidized housing, or kind of that was the conversation yesterday. Right, when you're moving kind of from the streets, right, from shelters or from the streets, like into housing, we're seeing kind of huge impacts on quality of life in any number of ways, right, reductions in physical health problems, and therefore reductions in all the health costs that we were mentioning above. There is an ample body of evidence that I can kind of find, also suggest that some people to kind of follow on Twitter, if you're on Twitter, Kelly Doran and Margaret, yeah, just go for the snark. It's entertaining. And Margot Kuchel and Josh Bamberg, like a few people whose work has been centered on, right, and they're all 3 of them are primary care physicians or ED physicians. And they are all kind of focused on social determinants of health, focusing on the homeless population. For exactly this reason, right? I don't know how many of you saw that the Benioffs gave $30 million toward this homeless initiative, kind of this homeless research center in San Francisco and the Bay Area. And the 2 people running that are physicians. And that is because there is a lot of evidence that I won't bore you with right now that, right, housing is medicine.
Yeah, and I think what I would say, though, all housing is not created equal, right? Sure. And so that's what we have to remember in that housing. Anytime we simplify the message to housing is healthcare or housing is medicine, right? We need to start really teasing out what the quality of the housing is that anyone is in, and then the historical health behaviors of the population, and then obviously always laying on top of that any racism pieces that underlay the health impact on the population. And once we start to do better in teasing all of that out, then we'll do better in being able to articulate truly what housing works for which people and what are the barriers that we have to overcome to have them access the housing that helps them best.
A question for Craig. In the MTO analysis, you had data from all-payer and Medicaid states. Did you look at those two separately? I'm sure you did, but I'm just curious about the findings because I worry that we would miss some people in the Medicaid states, who were doing better, therefore didn't qualify for Medicaid, and that would blunt your results a little.
Yeah, thank you. It's something we thought a lot about, like, do we combine these two data sources given that they're different, or do we kind of separate them? And so in sensitivity analysis, we looked at these separately. We found really consistent results with the all-payer, where we had kind of more data, and the findings were a little less robust in Medicaid. And frankly, I'm glad that the findings were more consistent with all-payer because kind of I have more confidence in those analyses for kind of a host of statistical reasons.
Hi. This is for Craig. I find myself thinking about the first study that you showed and showing that the impact for young girls was the most impressive. And I wondered why that is and if you had any thoughts about that. And I also wonder, were other contextual things adjusted for? Like, are they in neighborhoods with better schools that have better school nurses who are likely to get the kids into asthma action plans earlier, or the clinics around it, that kind of thing?
Yeah. So that's a great question. So first of all, we found that there were better outcomes for young kids who moved at an earlier age, and that was for both boys and girls. And then when we separated the kind of all kids into boys and girls, we found, tended to find better outcomes for girls. And we didn't separate out the young kids into boys and girls just because then it's kind of slicing and dicing the data a little bit too fine, and we want to just be careful with what we can say. I think for the young kids, I think there's kind of a host of qualitative data to suggest that it might have to do with kind of neighborhood integration, and kids that move earlier may have an easier time kind of adjusting in new neighborhoods, may be able to kind of find peer groups and other things that can matter. And kind of is consistent with the economic outcome findings. So we were really glad that kind of told a similar story. And then for the girls versus boys, we don't know for sure why that there are those differences. I think some of that may kind of have to do with some of the differences in kind of mental health that were seen in some of the prior MTO analyses where girls tended to do a little bit better. And again, some of that has to do with, kind of in qualitative work about where people tend to be spending time and the peer groups that they're forming in kind of their old versus new neighborhoods.
One more question? Anyone?
Could you state who pays for the moving costs for those in the Moving to Opportunity projects?
So for Moving to Opportunity, that was kind of a HUD-sponsored study, so it was kind of done under those auspices. For the Baltimore Regional Housing Partnership, it's through the settlement that was done in conjunction with HUD. I think as we're kind of thinking about kind of what's the next step, so BRHP has kind of given out the vouchers that they have, and they'll still be continuing to kind of use replacements about people that have moved out or no longer using the vouchers. But as we think about kind of, is there a way for kind of healthcare systems, which I think frankly trying to get healthcare systems to pay for the cost of the voucher itself is going to be really challenging. But to say, maybe that there's some upfront cost for mobility counseling that you're willing to kind of add on to existing vouchers may be possible, and that's something that we're trying to explore.
And those of you who were in the session yesterday, Allison Bell, who's on the housing team, would be upset if I didn't mention that this is a reason to apply for the mobility demonstration that'll be coming forward from HUD soon. This is using information like this is what helped advance that and make that available for folks who want to apply. And so that's thinking about your community and the impact that demonstration could have. This is one of the reasons why it would be important to apply. So I think we are. Do we have one more minute? Or okay, Harold.
Hi, this is Harold Simon from Shelter Force magazine, and I wanted to actually follow up on that. You talked a little bit about qualitative data, but there's, I think, a pretty significant literature on the racial stereotyping of black boys and how poorly they do in schools, whether or not they could do better. There's a long history of that, and kind of not thinking that that becomes not a big part of it, including by their own parents. So I think that it makes a lot of sense, sadly, but there's certainly the racism behind that is very clear.
All right. So with that, which I think is a huge important point to make in that spot, we will end the session. Thank you, Craig and Dan, so much for sharing your research. And next up is a break. Oh, are you going to do?
Hi, everyone. Well, you're almost at the end of the summit. You should be really sad about that. But we have a break here, and then we'll have a final plenary panel and just a short closeout. So hopefully you guys can stay with us.
with on PBVs also were our service providers for those other programs that are like Shelter Plus Care in many ways is very similar to mainstream in terms of the population it serves, services, but being a tenant-based model. And so that was kind of a natural fit. Actually, like one of our main Shelter Plus Care service providers in our county, we didn't get on board right away, but we've been like working with them to try to like bring them into the fold. But yes, so like the one PBB provider, Housing Hope, that I mentioned, they were the ones that just became a supportive housing provider for Medicaid, and then our Catholic Community Services is the one that we haven't brought in with mainstream yet, but we want to. It's just a matter of capacity kind of anything on their side, but they are a supportive housing provider through Medicaid as well, and I think they access that funding to
going to, what's it called? Oh, these are on the same channel.
One, two, three.
So A and C is what we need. Are all A's.
Last piece.
I didn't want it. I was looking like one of the series.
Good afternoon. Good afternoon. Well, I know the breakout I was in was fantastic. I'm sure, based on the clapping, that the ones in the other two rooms were as well. I'm so pleased to introduce the next panel. I don't quite know everyone on the panel as well as I know Colin Min from the Gates Foundation. He is the original, the OG supporter of this work. And last year, he was supposed to be on our foundation panel and got sick at the last minute and couldn't join us from Seattle. We're so pleased that he is in good health this May. But Colin truly has really just been very vocal about how important it is to do this kind of cross-sector work, specifically in the Pacific Northwest, but supporting that work nationally as well. And we're just immensely grateful for all he's done to promote that. So joining Colin, we also have David Fukuzawa from the Kresge Foundation and Susan Thomas from the Melville Charitable Trust. I'm very excited about this conversation. They're going to be touching on the theme of today, the equity, as well as discussing long-term goals of their foundations, but foundations generally, in terms of how they're thinking about how to fund cross-sector initiatives. We will leave some time for Q&A, but they'll be having a conversation among the three of them, and we're very excited to have you all here.
Great, thank you, everyone. So the wooden chairs have been brought to the stage. This is a symbol of how informal this session is going to be. When the wood chairs come out, you know that it's a relaxed environment. You know, it's Friday afternoon. It's the last session of a 2-day conference. It's sunny outside, and so you all are really the hardcore to stick through the last. Someone said to me just as we were coming up, you know, so are you ready to dazzle us? And I said, you know, at this point in the conference, dazzle isn't the right word. Keep awake is something that we'll settle for. So by show of hands, how many people were here 5 years ago for the first conference that focused on housing and education? All right, so not too many, and I think that that's a great sign. The people who are raising their hands are really the true OGs in all of this. And some of you, well, I guess only the folks whose hands have been raised will remember that one of the ways that we started the very first day of the conference 5 years ago was to play the dating game. And so by that, we had a panel, and we had Stephen Norman and Michael Mira, I remember distinctly, from the housing sector, with two superintendents from their local schools. And we set it up, they didn't know this, but I had set it up as that this was going to be the dating game. And so what I asked them to do was to stare deeply into each other's eyes and to tell the audience what brought them together. It was a very tender moment. I might not do that today if we had the opportunity. But I reflected on that because I thought that it really was a great way of showing the way that relationships get started. And in a lot of ways, all of the work that we're doing, the cross-sector partnerships that we're discussing, it's really based first on those personal relationships that you can develop, and then hopefully they build into institutional relationships. But I think one of the things that we recognized at the very beginning when we were seeding this work is how much those personal relationships mattered. And you know, I was just really struck. Sonia and I were just discussing as I was thinking about 5 years ago, the work and the way that this movement has built. I think a lot of that has really been based upon the relationships that have been formed. And I think it's really a testament to the work that CLAFA has done to continue to foster these relationships through these conferences and through the other forms of information sharing that they've managed. And I just want to give a particular shout out to Abra, because one of the things that's remarkable from my perspective is, 5 years in to any initiative, frequently you'll see a lot of changes in the personnel that have been leading these efforts. And I really think it's a testament to Sonia and to Abra the fact that they are still here 5 years later and that they're managing to kind of continue to do the work with the effectiveness that they have. So I want to give a round of applause to CLAFA for all of their work. So with that, I thought that 5 years later it would be ripe to continue to build on the dating game theme. And so my colleagues on the panel don't know this.
No, we
I
don't.
haven't briefed them on this part. But I started thinking about what is the role of funders in all of this work. If we had 5 years ago a panel of the folks who actually were dating, I started thinking, well, maybe funders, maybe we can think about ourselves as the matchmakers, the Tinder, of trying to create cross-sector relationships. So I'm not going to have them stare deeply into each other's eyes, but I am going to ask them to reflect on why they started thinking about themselves as matchmakers in this space, because it's not an obvious proposition necessarily. So I thought that it would be interesting to get started by asking them to reflect on their role as matchmakers in encouraging housing partners to get involved with other sectors, and to really answer, why did your foundation decide to get into the matchmaking business? Why are housing partnerships important and worthy of your support? So let's start with David.
Okay, so I'm so happy to be here. I'm sorry I couldn't be here yesterday, and congratulations to CLAFA in really advancing this discussion very broadly across not just health and education, but a number of different sectors. So I think that's an interesting question, because part of it started with our own kind of early dating experience, which goes back 11 years ago. And just to give you kind of a very, very broad background, in case you don't know Kresge. Kresge is actually one of the kind of original, they're kind of an OG foundation back in the 1920s. Kind of the classic period of American philanthropy. And for most of the 20th century, what we did was kind of fund buildings, like colleges and hospitals and things like that. And about 12, 11 years ago, with new leadership, Kresge began this whole new era, and I was kind of part of trying to create that. And to make a long story short, so I took over the health program, and given that we're an urban opportunity foundation, which literally is about working cross-sector anyway, what does a health program within that kind of foundation look like? And asking some people, what could we do quickly in this sort of area? And the one thing that kind of popped up very early on was lead. Talking about 11 years ago, and lead and asthma and things like that, which have been discussed here in other conferences. And at that point, and at that time, there were really hardly anybody doing this kind of work at a philanthropic level. The only funders in this area were really public funders, like HUD and EPA and CDC. So we started going and trying to get other funders interested in this work. So it was really trying to get funders to see housing as a social determinant of health. And I would say 10 years ago, that was not where funders were in terms of health equity and social determinants. They were thinking about healthy eating, active living primarily. That was the big conversation. So they were looking at things like food deserts and public transportation, things like that. So to even talk about housing as a social determinant was kind of like a new thing. But kind of what happened, then was as we got into this was the realization that the whole issue around substandard housing was actually related to a lot of other things. And the longer we got into it, there was a realization that there was a systemic problem about just the affordability and availability of housing for people. And then to go back to funders and say, you really have to think of housing not as just a one social determinant. It is a threshold social determinant. And it's a pitch I make to funders all the time, that when you think about housing, think of it as really a threshold, because without that, how are we going to get to the other things? And I'm talking about health funders primarily. So I've been in a kind of a rapid dating, kind of mode for quite a while, trying to get other funders sort of, interested in this. But then kind of getting the health players involved in this has also been a whole other dimension of this. And we'll probably, I don't want to spend it too much of the time, but I think, like sometimes what interests two people is realizing you have common interests. And the one thing we began to see is not only in the substandard housing issue, which gets into issues around childhood asthma, but especially on like high-cost patients, in which case, having some kind of supportive housing becomes a big deal. And so Kim Dempsey wanted me to bring up our impact investing side. And we began to realize that there was an opportunity in this space, to think of pay for success or pay performance kinds of investments in this area around permanent supportive housing, which got us also into sort of that end of the pool. And then this whole revelation began to open up to us that this is really, really a much bigger thing than just simply one set of things. There's something fundamentally wrong, about the way we do housing in this country. And now what we're moving towards is really the issue around stability itself as a public health issue, which gets into whole new sets of partners and connects to the folks worried about displacement and gentrification. So I'll keep it at that, just as an intro.
Yeah. Susan, how did you get into the matchmaking business?
So the Melville Charitable Trust focuses on preventing and ending homelessness. And we know and we believe, lots of smart people have told us, and there's lots of evidence that says that housing ends homelessness. And so I know that doesn't seem like a big aha, really? But yes, it does. And a lot of people, though, unfortunately, do not and historically have not responded that way in addressing the issue of homelessness. And so I loved Kamara's, I'm going to steal shamelessly from you. It's so funny, I just have to digress for a second, but I know Kamara from years ago from my time in Atlanta, and we belong to the same organization. You know how you know someone, but you don't really, know what they, deeply about what they do. And Kamara was always the one to hold us accountable in our group to do what we said that we were going to do. But I never knew you were such a badass. You are, but anyway, I just had to say that. But so that was in a good way, yes. But the visual, and you said it so well, is that when people fall off the cliff, they're falling into homelessness, and that's exactly right. And at the bottom, there are all these ambulances, and the homeless sector was created. I mean, we created a bunch of ambulances to respond to these crises of people falling off the cliff. But, the ambulances don't always take the people to where they really can thrive and where they can go. And someone said to me years ago, and I want to do a little experiment here, close your eyes for a second. And if that feels weird, you don't have to do that. And picture someone who is homeless. Now picture someone who has lost their home. And you don't have to admit it, but my guess is that your visions were a little bit different. I'll confess that when someone asked me that question years ago, my visions of the two people were very different. And that is our implicit bias based on the environment that we live in and work in. And we respond and create systems based on those biases. And so as you can imagine, the little ambulances down at the bottom waiting to take these people, some were taking them to not shelter or a temporary shelter, but to shelter as their new home. And there were all these hoops that they had to jump through to prove that they really wanted to be in a home, which is just really kind of crazy if you think about it. And so we've created a whole sector around this crisis response. And the trust has really operated within our sector. And we needed to create a response to the crisis. But we also need to think about a little bit upstream and what's happening, pushing that population back, up towards the beginning. And that is exactly where all the different sectors are operating that create the conditions where people fall off the cliff. And so we firmly believe at the Trust that homelessness really is a result of multiple systems failing. But our response is not a systemic response. It's a crisis response. So we started to think about that, and we started also to see that maybe about 4 years ago, homelessness overall started to decline. And so we said, that's not what we're hearing from our folks across the country. That's not what we're visually seeing specifically or especially on the coasts. And so why is that? And so we dug into the data. It was so important to disaggregate that data because that tells us the truth. And we saw that in high-cost cities, it was ticking up. We saw that that also demographically, people of color, that number wasn't going down. And we started to ask ourselves why. And we said, well, the high cost of housing. So it's important for us to really partner in a different way with the housing sector. And then we kept on asking ourselves why. Why is housing so important? Why? We were like kids, why? But the beauty of asking why is it forces us to dig deeper. And we started to think about the impact on health outcomes. We started to think about the impact on education outcomes, how disruptive homelessness is to a child's education, how detrimental homelessness is to people's health and to health outcomes. And in order to advance those outcomes, we really need to focus on safe, stable, affordable housing. I had dinner last night with Nan Roman at the National Alliance to End Homelessness, and she was saying that a national study was done, and they did, and it was self-report, but still, out of the 64,000 that they talked to, 32,000 were unsheltered. And of that, half reported that they became homeless as a result of health-related issues. That's not a homeless crisis. That's a public health crisis. There were 76% of the unsheltered population, of the women who were unsheltered, were trimorbid. 76%. Trimorbid means that you have a mental health disorder, a chronic health condition, and a substance use disorder. That's a public health crisis. That's something that the homelessness sector in and of itself can't respond to. And so that's why when in unearthing these things, we said, there's a bigger picture than just the homelessness sector, and we need to partner with other people.
And a similar story for the Gates Foundation. I work for the Pacific Northwest team. So we're the part of the foundation that focuses all of our grant making on Washington State. And it's a relatively small team within the foundation with two major strategies, one focusing on homelessness, family homelessness in the region, the other focusing on education. And when I joined the foundation, these two strategies existed completely in isolation from one another. The homelessness initiative had as our goal and metrics everything related to housing outcomes, nothing to do with educational outcomes for the kids. Our education folks didn't have housing instability or homelessness at all on their radar screen. And it wasn't until we started having conversations both internally as well as externally with some of our partners that we realized that this type of siloing that we frequently would decry outside of our organization existed within our small office within the P&W team at the foundation. And so luckily, in our community, we have some great partners who were doing similar thinking about whether or not they, as housing authorities, were really living up to kind of their full potential without thinking about whether or not the services and housing that they were providing were actually having an impact on the kids who were growing up in that subsidized housing. And at the time, we didn't even have the data available to answer that question. So really kind of through deep conversations with them about the work that they were doing and some thinking on our own end, we were compelled to start thinking about the relationship between these two strategies that existed within our team and our department. And that's what led us on this journey towards thinking about housing and education. And one of the things that I'll just add is that as we also at the same time started going deeper into really, let's name it, talk about racism that exists within our community and the opportunity gaps that we saw both within the educational system as well as in the crisis response system. One of the things that we knew we needed to have a better understanding is how race played out in our thinking about these two systems. And once we had invested in trying to create the data to better understand that, it just leaps off the page as to why you have to think about this work in a cross-sector manner. So one of the things that we were very startled to discover once we had done these data matching analyses is just how many African American kids within the Seattle School District were actually being served by the Housing Authority. What we found out through the data analysis is that about 38% of all African American Seattle School District kids are being served by SHA. We found out that of all, about 10% of all African American students within the district had experienced homelessness over 1 year. So you add those numbers together and you come close to 50% of all African American students within the Seattle School District are suffering from some form of housing instability. The district has announced that it's one of their top priorities to close the opportunity gap. The question then becomes, how can you meaningfully go about doing that without reaching out to the very folks who are providing housing services to those families without having them as a key partner in your work? So it really has been about building the case that you can't achieve any of your goals individually. You have to do them together. So my next question really gets to, okay, so through the processes that you just described, you developed a compelling point of view that these housing cross-sector partnerships were important. Can you talk about the grants that you've made, the tools and practices, how you've thought about using your foundation resources to try to foster the type of cross-system partnerships that you've wanted to bring about?
All right, let me try to be succinct here. And from like going way back. So, I mentioned sort of the healthy housing dimension. So we actually launched an initiative about 10 years ago now called Advancing Safe and Healthy Housing, which is really looking at sort of cross-sector approaches to the issue, because we knew that there were like public sector and some nonprofits that were working together. But what we want to do is really emphasize especially policy dimensions or responses to this issue. And so we supported a number of sites around the country to do that kind of work. So that was, and like I say, that led us to some other kinds of revelations as we were going through this work. And, so it led us to sort of think about, especially on the health side, what kind of money was there to sort of help. And a number of things kind of came up, sort of in that. And there was a bunch of things that we began to investigate via a number of grants. So, one was obviously sort of the Medicaid connection to, so let's say, asthma interventions. So that was sort of one stream of work, which, we started a while ago. And then I just mentioned, there was this opportunity in California, Los Angeles, around permanent supportive housing, and the fact that, there was not nearly enough capital to meet the need for the crisis that they're still experiencing there. And we entered into this partnership with the California Community Foundation, and using our investment side, to think about how we could use that form of capital to leverage more dollars into this space. And it was a much more complicated deal than just that suggests, but it was trying to leverage actually the donor advised funds at the California Endowment, which proved to be enormously successful. So we were actually able to raise that capital within a fairly short period of time. But then we ran into the fact that it's a lot more than a capital question. There's a NIMBY issue, and there's a systemic issue about, the issue of enough supportive housing is actually tied to the dimension of enough affordable housing. But what do you do in a city, where the pressures are great? To use Kamara's example, I mean, people are literally being pushed out, into homelessness, or into at least extreme housing insecurity, or just the sheer stress from that, is going to. So flash forward a few years, and so we've just launched one round of this all led us to this conclusion, that there is a profound crisis going on in this country that really is kind of all hands on deck sort of a thing. But it was our view, given the racial dynamics that we've heard about, and just the whole racialization of housing in this country, that community actually, not just a sector, people fundamentally needed to be part of whatever solution ensues, because people closest to the problem really need to be part of that solution. And I'm not saying that just in kind of like, a way of like, signaling virtue here. It's that what we were actually seeing is that people in communities were actually coming up with good ideas, but there was not nearly enough support for them. And what they needed was patient capital to really develop those kinds of things. So that's why we've launched this recent round of funding opportunity aimed primarily at communities, because at the end of the day, if they're not in the forefront of these solutions, you're not going to have solutions that are really going to stick. So I mean, and it's very new. We're going to have to figure out as we go along, so what of those places are really surfacing things that could be scaled or replicable or have other lessons for us, broadly speaking. So I just sort of say that because I think it's at some point we have to really address these issues around having people have the power and agency to really build their own solutions.
Terrific. Susan?
So we knew that we needed to not only look upstream, but also expand our connections and our partners. So we purposefully targeted different foundations and kind of e-stalked you guys to figure out what you were doing, what you were funding, and we targeted foundations that were not necessarily housing funders, but found themselves funding housing or housing-related programs because they recognized that housing stability was essential in being able to further the outcomes that they cared about in their populations. And really, we were talking about much of the same population. And so our response was to pull together a group of foundations, and we called it Funders for Housing and Opportunity. There are 12 foundations now. The Gates Foundation and Kresge Foundation are apart, so I've been dating both of them for about 4 years.
Who's winning?
I'm not going to tell. And it's a great group of large national foundations that that focus on various areas: health, education, social justice, economic mobility, and all of us have a commitment to racial equity. And we really wanted to center that in our funding and think about what would our funding look like if we centered racial equity and we funded across these sectors. And so we spent a lot of time talking about that and developing a framework that we felt good about, that reflected all of our values, in how we can fund. And so we felt that we could make the most impact in funding policy advocacy and organizing. Organizing really came in more recently, admittedly, since the change in administration. Narrative change. Really, how can we impact the way that people think about and talk about and deliver housing? How can we change the visions that you have in your head when you hear certain words like homeless, the homeless, which I can't stand that term. It's not a demographic. It is a situation. And then the third area, scaling what works. And so we all fund things that have worked pretty well. And how can we scale those things so that they can be replicated across the country? And then also, how can we fund and support things that we feel are promising and solutions, cross-sector solutions that work in community? And so we've focused on really funding just collaborative efforts. And so that's how we're encouraging collaboration, is to really, in our RFPs and in our invitations, look for those promising collaborations that are thinking about all these areas and that are centering racial equity and constituent voice in the center.
Yeah, and I'll just add on that, I think one of the things that we've observed is that, like personal relationships, frequently relationships aren't necessarily based at first on mutual attraction. So at the risk of embarrassing my housing authority partners, I think it's fair to say that when we started this work, there was more interest on the housing side than from their educational partners about the work that they wanted to do together. That it was more difficult, at least when we started, for our educational partners to kind of see what was in it for them. Why would they want to start dating housers? Do you think that's fair to say? Fair to say. And so despite how charming the housing authorities may have been, maybe they needed some resources to help their educational partners see why this partnership would be a valuable one for them to enter into. And I think there were a couple of ways that we thought our philanthropic resources could be helpful in aiding the situation. The first was the data. As I mentioned earlier, there really wasn't a strong data argument to be made for why the educational sector should partner with the housing authorities. In the absence of data that really could specifically nail down what the overlap was in populations, what particular schools had the highest levels of concentration of kids who were growing up in SHA housing or that were homeless, it's very difficult to make the case as to why this partnership should even matter. So one of the first things that we did was provided resources that could be used to try to enter into some of those data sharing agreements to answer some of those questions so that when the housing authority went to the superintendent of schools to say, here's why this partnership makes sense, you actually had a reason to take that meeting. The second thing I would say is that, the reality is these sectors use different language and have different goals, and frequently folks don't speak those same languages. And so one of the questions that we were confronted with is, how do we try to ensure that at least someone within each of those sectors understood the drives and priorities of the other sector? And I think Michael Mira from the Tacoma Housing Authority was one of the first folks to really bring this to operationalize this when he hired a former deputy superintendent from the Tacoma School District to come and work on his team at the Housing Authority. And so some of the most valuable resources I think that we provided was to allow for that type of cross-hiring. And people joked around that they started poaching each other. And there are good examples of people in this room who have gone from a housing authority to a school district or from a school district to a housing authority. And we view that as being a very positive move, that actually what that does is it embeds within each of those sectors an understanding for how you make arguments that others can relate to. There's a very real language barrier that needs to be overcome. And so by hiring people who speak education to work in housing authorities and vice versa, I think that we saw a lot of impact through that work.
Some people have used the term Sherpa, that we're in a period right now, and Peggy Bailey has been, I think, the first person I heard it from. You know, in this work, we need people who can actually understand these different languages, because it really is different languages. In the hospital sector, we're seeing you probably have heard this, some hospitals trying to build housing, and which is a good thing. But you know, I've been in conversations where the thing is, what's a tax credit? You know, and yeah, you're laughing, but this is real. And so, I mean, we're at the stage where, you know, there's going to be a lot of education, and we need those kind of people.
Yeah. Speaking of language, I was on a panel last week, and I was with two people who were in the community and speaking for the community. And they said, you know, you guys talk about equity, and in the community, we don't know, that means, you know, equity in your home. We're not on the same level. We don't talk about it in the same way. We use plain language, and I think that's so important in the narrative change work that we're engaging in, and we're trying to figure out what that looks like in our funding collaborative. You know, working across sectors is going to be a challenge. And so one of the places where we said we wanted to start was with values, because at some level, even if the language is different, can we get to a set of shared values? And then within our sectors, we can message it, you know, with our respective languages. But we really need to start thinking about what are those shared values.
Yeah, and just before we open it up to all of you for questions and answers, I mean, just following up on that, I think on the topic of narrative change, I was just having a conversation yesterday with David Williams from Opportunity Insights about the way that the narrative is so much stronger for all of us if we can talk about the way that we're thinking about the work in a cross-sector fashion. And I guess I would say, I think that this has been one of the main insights that I've seen come out of the Pacific Northwest, is that unless housing can be seen as a platform for better outcomes for families, housing will continue to just be seen as something that we're doing for the less fortunate, which is not nearly as compelling a message to a broad audience than housing is an essential component to provide people what they need to break the cycle of intergenerational poverty. The real connection between kind of addressing child poverty, upward mobility, all of those issues, depends upon the ability to use housing resources to lead to those better social outcomes. You know, I think one of the things that we were surprised to see in our data sharing was that even though you'd like to be able to say that with housing resources, kids do better than low-income families that don't receive those subsidies, the data actually is not clear on that point. So if you can't actually say that housing resources are making a difference in the educational trajectory of those kids, those dollars are always going to be questioned. So it's important to us to be able to share the cross-systems message to say that housing dollars are an essential, critical component to make the case that with those dollars, we know that we're going to see better outcomes for kids and for families. And so I think in terms of the narrative change, making the stronger case for housing dollars, as well as for all general anti-poverty services, this type of cross-systems thinking is really important to get to. So with that, you all have done an amazing job of hanging with us and staying mostly awake. We've got about 11 minutes left for questions and answers. 12, 15. So who'd like to start us off? Yeah.
Thank you. It's on. So I'm just curious if where your foundation stands in the topic of displacement. Since we talked about housing and housing dollars, I haven't heard the word displacement. So.
Start?
Well, it really is the focus of our most recent grant funding opportunity, which we call Advancing Health Equity Through Housing. We didn't put the word out quite as explicit, maybe, just because that word has all kinds of different kind of connotations, and people interpret it differently. And if you go into communities, they won't use that word; they'll use gentrification. But that very much is kind of what we're trying to address. Having said that, it's a very complex issue, but we see it as a true public health problem, insofar as it leads to really, housing instability, which is tied to stress in particular, but other things. So it very much is core to how we're thinking about it. We're part of another major funding collaborative called the SPARK, or Strong, Prosperous, and Resilient Communities Challenge, with a number of foundations, including some of them here, that is focused on equitable development in 6 communities. And even though the original focus was on transit-oriented development, in every single one of those communities, what the community is saying is the priority is displacement. So I think, I don't know what the solution is, but that has now become kind of the priority in those places in terms of development. How to develop, without putting people out of their homes.
Mm-hmm. It's extremely relevant in what we're focused on, homelessness, because that's a driver, is displacement, and people no longer being able to afford their homes, being forced out of their homes, particularly since the housing crisis. Our double-edged sword on how to address it with our partners is we are advocating for housing affordability. Along with housing affordability, part and parcel, an unintended consequence is gentrification and displacement. When we invest in communities and build communities from the inside out, and so we agree that the mobility is both and, that we are encouraging mobility to high opportunity neighborhoods, but also encouraging investment in low-income neighborhoods where people are, where affordable housing is. But that double-edged sword also is then, how do you make it affordable, make it an area that's thriving and where low-income households can connect to opportunity in their area without attracting higher income people who will price them out of their homes. So we haven't figured that out. If you have, that would be great. You can tell us.
Yeah. We can talk after. No, I'm just kidding.
Yeah, but that's our double-edged sword.
So Colin, hi there. I don't know if they have a TV show where they take the participants in a dating game and 5 years later they look at the results of the relationship. But he left me for another housing. He left me for another school district. And the reality is we have 3 school districts that we've been partnering with deeply. And over the 5 years, I think we've had 10 different superintendents cycle through those school districts. And part of the challenge is, how do we create enduring institutional partnerships? Much of what I think the progress we've made has been made through chemistry with individual leaders. And the challenge is, how do you get beyond that? How do you get beyond the foundation support, which is always fleeting, to create long-term structural incentives for these kind of partnerships? You'd like to think that recognition that the synergy is beneficial to both would be enough, but it rarely is. And we've looked at things such as putting into federal grants bonus points that get embedded in there on an ongoing basis. We've now got a superintendent on our Housing Authority Board of Commissioners, but that's not mandated by the state, unlike, for example, having a labor leader on the board. And I'm curious from the 3 of you, what you think the best long-term strategies are for really creating solid institutional relationships that are not dependent upon individual relationships or temporary funding from a foundation to create a partnership?
Yeah, that's a great question. I actually think that this may not answer your question perfectly, but I think no matter what the issue, we're at this era right now where we have to create whole new kinds of governance structures that span different sectors. Like, health and housing, or education and housing. I think all three of them actually should get together, which means like creating the kinds of tables where people make commitments, and that we find ways that connect data, because part of the issue is how do we connect data between any sector, whether it's housing and education or health and housing. One interesting thing on the education front, we funded an effort in Lehigh Valley with a hospital, because they were they had created all these school-based health centers. But the students, there was this high rate of, I think this was the issue you guys were finding out, was a high rate of transience. And so they would go from place to place and they could not track the students. This is kind of pre-ACA, and so they created a common database that went across 3 school districts, all the health systems. And to do that, they really had to create the infrastructure on the data sharing, on the policies, in terms of the students, in terms of how the treatment. So, I've seen it done, but it really requires people's willingness to create whole new structures, that can also then be tied by funding. And I think what health systems are trying to do is use different kinds of mechanisms like accountable health, et cetera, to provide the sort of funding for those kinds of things.
I agree. Creating that structure and creating that table that you talked about. And an example I can give, when I was working in Atlanta, I was working on a citywide, and it was really a city and county wide initiative for homelessness for the mayor's office, and was very concerned about the sustainability of the work that we were doing. And so what I didn't want was a mayor's blue ribbon commission to help with this. And so instead had an advisory board that was comprised of, as David said, people who had the decision-making authority, either over people or over budget. And from different areas and sectors across the city. So we had from state government, county government, philanthropy, corporate, and so that mix of people and decision makers was able to be sustained even until now. So what we ended up doing was creating a 501c3, and then just imported those people onto the board. And that organization is still going, and now Atlanta has recommitted $50 million public-private funding for homelessness, and now that entity is the holder of those, and the administrator of those funds. So as an example. Mm-hmm.
And I guess, you've hit it right on, Stephen. That's the most challenging question, I think, for all of us as funders, is the long-term sustainability. And I guess I keep going back to and thinking about your question that ultimately philanthropic dollars have to my mind, morph into public dollars. That's the only sector that's going to be able to continue this at scale. And so I think part of our aspiration in seeding the work is to, through developing the best data systems that exist, to kind of prove out the value proposition of the work moving forward by supporting narrative change and advocacy efforts that, in some way that we can build the case for ultimately a public funding source that can continue to support that, because resources are always going to be scarce on the core missions, no matter what sector you're from, and additional dollars will be necessary to try to build that. So it's not an easy answer by any stretch, but I think that ultimately paths lead towards local, state, and federal funding sources. I don't think I have. The other thing that I would say is that I think in terms of the way that we can build the structures to try to keep things going beyond the personal chemistry that one might have is to try to seed it at multiple levels within the organization. So while there's turnover at all levels, what we've tried to do is to try to create opportunities for those connections to be made at the superintendent ED level, as well as at the kind of staff level, as well as on the ground, so that even when those changes occur, if things aren't clicking on all cylinders with one level of the relationship, maybe there's enough sustainability on other levels to keep the wheels moving.
Yes, there's been like a push for scalability, and every state, city, neighborhood has different nuances. What are some of the best examples or practices that you've seen that make a scalable model?
You want to take that, David?
There was this big announcement by, was it Gates? I forget now, in Seattle for housing and
Microsoft.
Microsoft, that's it. And then knew there was a connection. And in the Bay Area, and for basically new capital. And I've come to the conclusion that while we certainly need to build more, in terms of scalability, and we know different ways of doing that, and there's some emerging things. I think it has to be a policy solution, because if we don't recognize this, that there is a scarce amount of real estate, especially in some of the high pressure cities, but just in general, to house people, with more people moving to cities. So there's got to be a policy solution that recognizes this as a problem and prioritizes it. So I'll say that, and I think there's some examples around the country that have been doing some things, and in Colorado, some interesting things around ADUs, additional dwelling units, and then in LA, there's a thing on rapid transit where there's a policy around developers having to have so much affordable units around, TODs, T-stops, things like that. I think are promising. So I just sort of say that, but I also think that, get back to my original point that, and there's all kinds of things around rent protections that I think are important, but I think even despite all of those things, there really almost needs to be a major, and this is why we're focusing so much on narrative change, just a major shift in how we talk about housing in this country. Because without it, I just don't know how we get to a truly scalable solution.
Mm-hmm. I have an example from homelessness, but hopefully we can see the connections. Using data, people were able to prove the effectiveness of housing on health and in the health system, and the cost effectiveness of housing. And we were able to prove with data the impact of permanent supportive housing. And that caught a wave across the country. It caught a wave with state-supported subsidies. It caught a wave through federal funding. And it was that evidence that showed that this works and these set of conditions work, that was able to take that to scale. So I would say, in your local jurisdiction, the things that you're working on that you would like to scale, use the data, use the evidence to be able to socialize that and get the support that you need.
And I would just add, I think it's our hope that the past 2 days are kind of a tool towards scaling. That what you've heard today and yesterday are examples of things that are going on in different local communities that can be brought to other places, and Funders for Housing and Opportunity is meant to try to, one of the topic areas, as Susan mentioned, is this idea of can we provide philanthropic resources to scale and to bring solutions that seem to be having some promise in one part of the country to others. So for example, House Ed, which I know that there was a session on. Jennifer Peck is here from Partnership for Children and Youth. That was a program that deliberately brought together folks from the after-school sector to the housing sector and started working together in the Bay Area. They've now been very successful in kickstarting an effort in the Pacific Northwest to try to bring that model to another part of the country. In some ways this goes back to Stephen's question earlier. CMTO, another good example of a common research base that in the Pacific Northwest we were able to pick up and run with, and now there's federal appropriation for those types of efforts moving in other parts of the country. So I think of scale and sustainability as really being kind of the same thing. And I think all of this and really the value of this conference has been trying to build the movement to ensure that all of this work can be brought to scale and can continue to be sustained. So do we have time, or should we? So one more question.
This is a kind of broad question, and I want to set this in the context of you guys as philanthropists kind of get to see a lot of really cool solutions that hopefully will kind of save us all in the end, working together. And relative to housing, I mean, we've all been fighting the battle of affordable housing for years. The numbers of public housing units have come down. There have been alternative plans, RAD and some other things to develop housing and all that kind of stuff. But the population's increased, the number of public housing units proportionally has not even increased that much. At the same time, the population's aging. The number of folks with defined benefit retirement plans is few even had defined contribution retirement plans of any kind. And Susan talked about falling off the cliff. And as our numbers of baby boomers are aging, myself included, 202 money for elderly housing going down. I guess I'm wondering, are you seeing any solutions to make sure that all those folks don't fall off the cliff, because the numbers just seem astronomical, and not to mention the fact that the housing stock, and everybody wants to stay in their home and home-based healthcare and that kind of stuff, but we've got a suburban model that does not sustain very well for folks who at some point can't drive anymore, would like to be able to just walk and see friends or get to a store and that kind of thing. So I'm just curious if there's any kind of long-term visioning plan out there to address it. We've posed the question in the past to folks at HUD and other organizations, and they're frustrated, and some of it's a planning question, a resource question, a will question, and I don't want to deal with it question. So I'm just wondering if you're seeing anything and have any ideas or any models or anything that we can look to or work to.
Okay, so a nice upbeat softball to close down the to close down the session. Anyone want to take a crack at that?
I wish I could say yes, but I can't. There has been a lot of discussion going back, starting a few years ago, about what we're going to do with the aging baby boomer population, and I don't think that people outside of the housing sector, outside of the social services sector, even within, really understand the magnitude of the issue that we're facing. And so there's been discussion. The Bipartisan Policy Center pulled together a group headed by Secretary Cisneros to try to figure out solutions. AARP, other organizations have been talking about this and have put out briefs, but no one has come up with the cry that we need to move now. So it's a very relevant issue, and we have not moved fast enough to address it.
Yeah, the BPC piece is actually, I think, a useful framework because because they also talk about the fact that in terms of long-term supports and services, we're not nearly ready, and like who is going to even staff them, especially if we keep immigrants out of the country. But so that actually is a framework, but I'm not, to Susan's point, I haven't seen anybody say, yeah, we've got to do this, because it really involves a strong federal response at this point. And it's going to be hard to get there without it.
So with that, thank you.
Good job.
Well, thank you so much to our panel. We'll just do another round of applause for them. Colin did a pretty good job of plugging the conference for us, so thank you. But we really do truly hope that this was a meaningful almost 2 days for you, and that you met someone that you want to follow up with, you heard about something that you want to bring to your community, and you were also able to share the innovative and exciting work that's happening in your own community with other attendees. This is all about cross-sector partnerships, working together, whether you're looking for a short-term engagement or a golden anniversary with those partners. We really do hope that it's meaningful and making change for the people that you're trying to serve. So I think we have, Steve's going to share a couple takeaways as well, but please turn in those evaluations if you haven't already. Really rely on that feedback, and we're so glad that you could join us and be a part of this work.
So I really appreciate that Colin brought up dating as a metaphor, because often on calls with members or I'm in group meetings, I've said this is a first date question, this is a third date question, this is a year going steady question, but keep them all in mind. I think actually it's an apt metaphor, don't give up after a bad first date, don't give up after bad 3 first dates, but if you have 10 bad dates, you might need to cut it off. And I have to say, Susan, I don't know where Susan is. I had an aha moment when I was listening to her, the exercise closing your eyes, and I definitely had a slightly different image in my mind, but what I kept thinking about is there's not much that distinguishes these days those two images. It's very easy to move from one to the other, even if it's an immediate loss of home and being homeless, chronically. And it also made me think that there's a lot of potential as the national conversation is starting to involve housing. The national conversation has touched on healthcare. The national conversation has touched on education. These are values that I think a lot of people believe in, and I don't think they always realize how much work goes into the safety net. And I'm always just humbled to be in a room full of people. You guys do this work. We're in DC here to help, but you guys do such extraordinary work in your communities, and it's a privilege to be able to bring you guys all together for this conference, and we can't wait for next year.